Okay, hello everyone. On behalf of the Global Health Network, a very warm welcome and sincere thank you to our participating audience for joining us today, and to our ZikaPLAN partners, Annelies, Sonia, Lida and Selina, for leading the content of our session today to demonstrate some of the key lessons learned from the perspective of a research network which was set up to address and respond to Zika, and from this standpoint, what applies to the emerging challenges presented by COVID-19 and beyond. So we're excited to be here co-hosting alongside ZikaPLAN, and I will now pass over to Annelies as our chair for launching the session.
We are going to start today's webinar. Good morning or good afternoon, depending on where you are. Welcome today to our webinar entitled Lessons from a Zika Network to COVID-19 Response and Beyond. This webinar is organized and co-hosted by ZikaPLAN, and ZikaPLAN stands for Zika Preparedness Latin American Network. So it's co-hosted by ZikaPLAN in partnership with the Global Health Network, which is based at the University of Oxford in the United Kingdom. Thank you for attending today, and welcome to those joining via Zoom or via Facebook. My name is Annelies Wilder-Smith. I am a professor at Umeå University in Sweden, and I'm the ZikaPLAN scientific coordinator. I'm delighted to be joined today by three members of ZikaPLAN, Sonia Leonard, Lida Osorio, and Selina Toki, each of whom will offer a short insight into their specialist fields in an effort to share our experiences around how we, as a consortia, are responding to the COVID-19 pandemic. In particular, we will hear from our panelists in terms of presenting aspects of research and management of Guillain-Barré syndrome during especially the Zika pandemic, and how it now translates into the COVID pandemic. The role of academia in outbreak response, clearly a very important topic, and exploring the parallels and learning from the parallels between the Zika pandemic and the COVID-19 pandemic. And then also discussing major research challenges. So during the first half of the session, we will hear from each speaker, and then the second half will be dedicated to discussion with questions and answers from the audience. To interact with the panel and ask your questions, please use the Q&A box in the toolbar. For those on Facebook, please also share a question in the comments. Please introduce yourself first with your name, your role and location, and we'll try our best to get through as many questions as possible. If you wish, you can also interact with us on Twitter today and find out about future events at the Twitter for TGHN. This webinar is being recorded and will be shared via the Global Health Network for reference and for those unable to join us today live. Now let's make a start. And our first speaker today is Sonia Leonard. Sonia is a medical doctor and a PhD candidate for the Department of Neurology at Erasmus University in Rotterdam in the Netherlands. Her research focus is on Guillain-Barré syndrome, especially associated with the Zika virus. Her research group in Rotterdam is leading the largest international study group on GBS, and she will share more about it in the next few minutes. And Sonia, I'm also very pleased to say that Sonia is part of the ZikaPLAN consortium. Over to you, Sonia. Thank you.
Hi, everyone. It's an honor that I'm invited to talk to you in this seminar. Let me just share my presentation with you. So what I wanted to talk to you about today is the Guillain-Barré syndrome, and then focusing on research of this rare disease in times of pandemics and the bottlenecks that occur and how to deal with them. So to freshen everybody's memory, the Guillain-Barré syndrome, or GBS, is a rapidly progressive immune-mediated polyradicular neuropathy. It's a rare disease occurring in about 1 in 100,000 people and can be triggered by infections. About 20% of patients are admitted to the intensive care unit, and 2 to 12% die, depending on the care that is available. So it was already shortly highlighted by Annelies, but the reason that I'm now talking about this disease to you is because the Erasmus MC is leading the largest international study on GBS called IGOS, which is operative in more than 160 hospitals in 22 countries around the world. And we have included almost 2,000 patients with follow-ups of 1 to 3 years at the moment. So another reason to now talk to you about this rare neurological condition is that outbreaks of GBS can occur when large epidemics or pandemics of infectious diseases that can trigger GBS take place. So this was seen during the Zika virus pandemic in 2015 in Latin America. And this was also the reason that our groups joined ZikaPLAN to investigate this further. Now, another reason to now talk to you about this is because during the pandemic with COVID-19 that we're facing now, multiple case reports and case series have been published that suggest that there might be an association between this new virus and GBS. This is not the first time that infectious diseases or agents have been associated with GBS. The first infectious agent to be associated with an outbreak of GBS was the swine flu vaccine, which was given in the United States in 1976 and was followed by an about 8 times increase in the amount of GBS patients. Then in 1995, the first infectious agent was identified in relation to an outbreak of GBS in northern China, when there was a large increase in cases of GBS, and they were later connected to a diarrheal bacterium called Campylobacter jejuni. As you can see in this timeline, Campylobacter has caused multiple outbreaks in the past years. And also in the recent 2 years, large outbreaks of GBS occurred in Peru, which were later connected to this bacterium. So the question which this timeline, I think, raises is what can we learn from these previous outbreaks, and how can we best prepare for outbreaks of GBS in the future? So when you're researching GBS in relation to an outbreak of infectious disease, I think there are 2 main questions. One, if there is a true association, and 2, the impact in terms of both frequency and severity of GBS. These 2 questions come with a lot of requirements for the study and study design. So firstly, if you want to determine the impact in terms of frequency, an international surveillance platform would be necessary that captures both the incidence of GBS between and during epidemics. However, this is currently not mandatory and not being done in most countries. Then, if you want to study the association between GBS and infectious disease, you need a cohort study with a case control design. However, this is notoriously difficult, both to design, but also for clinicians who are recruiting patients that also they need to recruit controls. Then what's often seen in studies that are haphazardly set up during an outbreak is that long-term outcome is not documented, which means that the impact for patients is often missing in research set up during outbreaks. Then it's of course important to have a sufficient number of cases with GBS in the research that you're doing, and also both to determine if there's an association, but also to determine if there are specific features of GBS in relation to this specific pathogen. So we know that some pathogens are associated with specific types of GBS, and which are sometimes more severe. So if you want to study that, you need a lot of patients, and this would require often a multi-center or even international study, as this is a rare disease. Then lastly, ideally, you would want to compare also to determine if there is a specific type of GBS related to this pathogen to other previous studies on GBS. And this would require harmonization of protocols with studies that have been done previously. So as you can see, these are lots of requirements for a high quality study, which are not easily set up during an outbreak. Then, even if you have the study design, there are some requirements, of course, for the study infrastructure to be able to start. So everybody knows that in order to do a study, you need funding and, of course, ethical permission. And everybody also knows that this takes time from application to receipt, and which is usually more than 2 months or maybe even more. Then, if you're collaborating with other centers and you want to analyze your data, you need to be able to share these data and samples. And this often also causes delay because there are strict regulations to share data and samples, such as the GDPR in Europe. So this is also what we saw during the Zika virus pandemic. On this timeline, you can see the amount of suspected and confirmed cases in the Americas. And you can see that the amount of cases peaked in the beginning of 2016, which is also the time when the WHO declared Zika virus a public health emergency of international concern. However, Zika virus research, which was funded by the EU, including ZikaPLAN, which we are part of, could only initiate in October 2016. And by that time, a lot of involved researchers still needed to set up the study or get ethical permission. So this shows that the window of opportunity to really research this pandemic is easily missed. So the question is, how can we improve this in the future and also during the current pandemic? So if we go back to the requirements for study design, ideally, of course, you would set up a surveillance for GBS, perhaps similarly to what is done currently with polio, in which all patients under the age of 15 with acute flaccid paralysis need to be reported. Perhaps a similar type of surveillance could be introduced for all ages. Then what's possible is to already define a research protocol with a case control design that can be adapted during an outbreak easily and can be implemented in a faster way. Then this research protocol could also include long-term follow-up, and in order to get a sufficient amount of cases and to compare to other studies, the easiest thing to do is, of course, to use operative international consortia such as IGOS, but there's also lots of other international networks that do research on GBS. So regarding the study infrastructure, this is of course also a difficult point, but there are already initiatives in place that ensure the fast mobilization of funding, such as GLOPIT-R, which joins together major research funding organizations to quickly start critical research during an outbreak. And perhaps it's also an option to create something like interpandemic funding, where you would only use the funding when the next pandemic occurs, but you can already start planning the study. Then regarding ethical permission, some countries already have in place the possibility to have a fast-tracked review or incomplete IRB review in case of an emergency situation. And the NIH recently launched the idea of a universal IRB, or what it actually means is that in case of a multi-center study, that you would only need a single IRB approval, because the situation as it is now is that you would need every single center that joins your international research to have an IRB approval themselves for their local center and not just one. So the suggestion is to just have one single IRB approval for multi-center studies. Then for sharing of data and samples, perhaps it's possible to already have pre-approved agreements ready. So going back to the time before the Zika pandemic, where we were at with our GBS research then, comparing to now. So this is a map showing the countries that were participating in IGOS before the Zika pandemic. And here is where we are at now. So with help of this funding from ZikaPLAN, we were able to collaborate with lots of centers in Brazil that now joined the study. And we were able to set up a case control version of the study called IGOS Zika that's also operative in Argentina and Malaysia. And we have increased our network in an important way. So we're collaborating with, for instance, the NIAS in Colombia, with a large collaborative group in Southeast Asia, and other partners from ZikaPLAN, and of course with the READY and the Global Health Network to also share our study results. Furthermore, before the Zika pandemic, there were no international clinical guidelines for GBS. And together with a large group of international experts, we were able to write consensus guidelines for GBS, which is also available in an online version, thanks to Ready, and will be translated to other languages as well. So in conclusion, we've already come a long way since Zika, but there are definitely going to be outbreaks of GBS in the future, perhaps also currently during the COVID-19 pandemic. And we need to learn from these previous outbreaks and improve our research preparedness. So if you're interested, we also recently published a short article about this topic. So you can look it up if you want to read it. And later on, I'm happy to take any of your questions.
Thank you, Sonia. We will have questions at the end. So it's now my pleasure to introduce the next speaker, and that is Lida Osorio. Lida is a medical doctor with a PhD in epidemiology, and she did a postdoc in clinical R&D. She's now professor at the School of Public Health at the Universidad del Valle in Cali, Colombia. So we have a very international team today from Colombia, from the Netherlands, and later also you will hear someone from Brazil. So thank you, Lida. And Lida will talk about and deliberate on the role of academia in outbreak response. Over to Lida, thank you.
Thank you very much, Annelise. Could you confirm that you can see my screen now?
I can see your screen and your face.
Thank you very much. Thank you, Annelise, and thank you to Bonnie and all the people who have made this possible today. I'm very happy to share with you a little bit of the perspective from a public funded university in a low middle income country facing 2 epidemics in less than 5 years, which we are not really well prepared to do it as most of the world, as evidenced by the situation, the current situation. But I think that a lot of the lessons that we learned is going to make us stronger and be able to have a better response every time. So the missions of the academia, it's not passing my next slide, it's a bit slow. So I'm carry on, okay, while the page moves. So the mission of the academia is basically education. And for that, then you have different kinds of areas of teaching. And in health, they are the first response. So both for Zika and for COVID, the first line of response is the healthcare worker. They also had the public health workforce as well, that has been educated by universities. So it's a very clear mission, area of mission by the universities in response to epidemics. Research, of course, that is done at the universities, and then it's used in deploying different interventions to prevent and manage and mitigate different health hazards, including epidemics. But I'm not going to talk about this because this is going to be addressed by Selena in the next talk. And the other one is social engagement, which is very important because it's not only the training and research, but actually how both the healthcare workers and the developments that are done at the university actually impact the quality of life of the people around the universities or in the regions beyond. I think the first most important capacity in the response to epidemics, as evidenced by both Zika and SARS-CoV-2 outbreaks, it's been the capacity to do molecular-based diagnostics. So both viruses require molecular-based diagnostics. And the public health sectors in our countries, low and middle income countries, usually don't have the facilities nor the resources to rapidly standardize and develop molecular-based techniques. So this is a primary capacity that universities are able to pass on. First develop, and then provide the services for diagnostics, and also transfer this technology to the public health sectors and also private sectors for labs that currently can offer and increase the coverage and access of the communities to molecular-based diagnostics. This also requires training in this transfer and also quality control. So better suited labs which standardize protocols in how to develop and transfer and supervise the quality of these technologies, I think is very much a lesson learned from both epidemics. But it's still a formal process in how to do it, and the funding for the universities to be able to respond quickly in this, because it requires reagents and personnel that has been working 24 to be able to provide the services required for the epidemic response. Also, there are other lab-based techniques that are also required for both diagnostics and seroprevalence studies. There are antibody detection. There's also the capacity at the universities to do it, as well as tests that evaluate if these antibodies provide some sort of neutralization effect. So if are able to neutralize the virus, and hence it could be a proxy for some sort of protection that can be further used in the vaccine studies. So this also has been able to do it in our own lab at Universidad del Valle. So there were some tests developed first for dengue, both antibody and neutralization assays, and then for Zika. And it was very obvious to us that we also needed this test to be allowed for SARS-CoV-2, and then it requires viral culture. So the level of safety of the labs that are based in the universities is also an important issue, because this is a respiratory virus. So you need a more safety level for the lab. So this capacity, and to keep this capacity in universities to have high safety level safety labs, is very important. And then it could be also used to develop new tests, and also training for people who is able to do this later on in the public and private sector. Virus sequencing has been key to the diagnostics and outbreak investigations in both Zika and SARS-CoV-2. And for this, I want just to point out the new technologies for rapid sequencing has been transferred through the universities. So for example, one of the first viral sequencing in Colombia was done by Universidad del Valle using the Minion approach, which is a novel rapid sequencing approach. So these novel technologies that be able to provide data that can be used rapidly to understand the transmission dynamics of epidemics, then it can be done through the universities as well, who are sensing all the time all these new technologies to be able to be used in practice. And finally, and not less important, is the validation of new diagnostics. So both in Zika and SARS-CoV-2, you have seen this incredible amount of new diagnostics, rapid diagnostics using different technologies. And it's not clear how good they are, or what is their performance before they are used in routine care. So universities can also help to do the required validation studies to provide the guidelines for the correct use and deployment of the new diagnostics. It also requires certain protocols that can be easily put in place, and can also be done using multi-center studies to make it faster as well. Diagnostics also may perform differently in different populations. So you need also to be able to access to different populations, and then universities usually are attached to hospitals, university hospitals that provide samples, or lower level of care hospitals as well, to have a wide spectrum of the presentation of the disease. And in the case of Zika, we have done this in trying to validate new diagnostics, but still it's necessary also to go beyond that, to leave the lab and do also some field validation of diagnostics. So this capacity to laboratory-based diagnostics is not only based within the walls of the lab and with the equipment of the lab, but how do you actually validate new diagnostics in the routine care in the field? So this combination, epidemiology and technology and human resources experience in lab diagnostics, is also required for correct epidemic response to both in the case of Zika and SARS-CoV-2. So we're still doing that for both Zika and COVID, in how to improve diagnostics, which are key to the public health interventions. In addition to lab-based, I think the second that has been more important in terms of supporting the government response is the data analysis capacity. The amount of information that is being generated is incredible. And I'm just using a local example, not to talk about the amount of data that is being produced globally and the open sources of information that we have now. We have so many control tables that we can access openly, download data. Everybody has the more or less the capacity to do very simple diagnostics. So how to make sense of all this information is very difficult from the public health perspective. Usually our governments have been doing routine surveillance, but at the time of epidemics, this is on top of the routine activities. So you have to do surveillance for all the other public health events. And now you have new events that you need to develop new protocols to do the surveillance, train the people who is doing the data collection, and also curate it, analyze it, synthesize it, report it, interpret it, and make decisions based on that. So you have to really go through a very careful and detailed process that in our situation has actually make it difficult for the public health workforce to carry on the routine surveillance, the routine healthcare activities, plus the outbreak response. So universities have been able, at least in the cases that I've known, to help, to contribute with the teachers and MSc students, PhD students, to provide key data. And I think one of the most important aspects of this relationship in data analysis is actually how we are going to train our students, ourselves as teachers, in how to handle this data that is very delicate, because we need all the details, the names and addresses, contact details, mobile numbers, even you see this is very only an example of geographical data. So we need location, the exact location of the cases. In the case of COVID, you see there we're producing detailed maps of every single case, even from probable case definition, point by point. So we now have more than 100,000 cases in the city from both probable and confirmed cases. And all of this has been mapped point by point. And you know, when they report addresses, it's not very standardized. So you have to go a very automatic process, but it doesn't cover all the data curation, so you have to do a manual. So we have students who are volunteering to do that. And we also did the same for Zika. So we already have the expertise in how, being trained by Zika, in how to produce this kind of information that was very important to take interventions to the places that are being shown by the maps that are having the highest burden of transmission. So there are also data analysis in relation to the epidemic curves, the behavior of the epidemic curves, and how to advise the governments in what to report to the society and interpreting that. So we did that with Zika and what we meant for pregnant women, and also we're doing that for COVID. So that's been very important to have the full package of data analysis in how to handle information, properly curate it, synthesize it, analyze it, interpret it, and able to communicate it to take informed decisions. The other area that the academia has been shown to contribute to outbreak response is development of new interventions, innovative interventions, and those that are contextualized. So not all the interventions that are applied to Zika in one place can be actually implemented or have the effectiveness required in other contexts. So developing this capacity to have the universities able to produce certain technologies has been very important. And here I think there are two lessons between the two outbreaks. These two examples are developments at university for COVID. So we know hand washing was very important from the real beginning. There was a shortage of hand washing devices for public spaces, and the ones that they were putting up, they were vandalized. So we need to have a very strong unit to do hand washing in public spaces in the city. So the engineers were able to produce the hand hygiene unit that you see in the slide. And the other one in the other photo is this separation between people in the public transport, because the transport has been severely hit by the fact they cannot carry as many people as they normally do. So how to accommodate, you know, the bus, what to redesigning the bus has been supported by the university. But it's not just the intervention, but it's how people use it. Is the educational component as well. The messages, the health promotion activities that universities are able to do and have all the theory and background, and also the force through their students to provide the required educational messages and activities that accompany these interventions. So in ZikaPLAN, we work with the London School of Hygiene and Tropical Medicine to produce and to actually implement, using education, health education theory, for women to use repellents, wearable repellents. So pregnant women, for Zika, we be able to prevent the biting of mosquitoes by wearing wristbands or shawls or certain clothing with repellent activity. But for that, you need to have research to produce safe and efficacious wearables, but also the educational messages and strategies for them to use. So I think it's very important in the sense that the Royal Universities were developing interventions is not only to produce the hard materials, let's say, but also all the processes that accompany the proper use of the intervention so that is efficacious in the field. And sometimes we forget that. The university just put up the news press about the intervention, but all the education that needs to go with the intervention is probably overlooked, and the funding and the evaluation of those educational interventions as well that goes with the devices that are developed. The other area is the multidisciplinary training. So these are new viruses, new diseases with basically no knowledge and a lot of information being produced daily that needs to be processed, need to be critically appraised. And then academia has this capacity to do this, synthesize and then put in a format that can be passed on to people that need to know this information and need to be permanently updated in the new developments of the disease. So for Zika, then we have like fora, materials, protocol. I think the first challenge for Zika was actually something that happened as well in COVID. This is real. There is an association here, even if the case control by Selena study was not published yet. This is something that is happening. It's real. So you need to prevent this mosquito bite, especially in pregnant women, because this is potential of these congenital malformations. But still, a lot of people didn't believe that. Even gynecologists, obstetricians, some of them still were skeptical because they haven't seen the strong association results of the studies, because they take time to be conducted and analyzed and reported.
Lida,
Same for
one
COVID.
more minute.
Yes,
1 more minute.
I think this is 2 more slides. And then also same for COVID. It was, so part of the message was by the academia, with this credibility of the professors, the good branding of the universities, were able to accompany the government in the messages of communicating the risk. This is real, something is happened. And these are the kind of interventions that we know it work, and also to train the physicians and the health work in how to manage patients, what kind of treatments we're able to provide, or what supportive care, etc. And also in the case of Zika. And finally, I think there is one that it's usually not recognized, but is the leadership. How universities have a role to play in counterbalancing the situations that may go beyond what it could be done by the government, let's say. So it has to counterbalance powers. And I think this is a photo of our dean, and then this is a photo where we were in the Senate discussing the interventions done by COVID. For Zika, there was less than that. And I still analyzing what happened with the situation in Zika, that we were not as visible in terms of influencing public policies, and also to analyze ourselves a little bit more in academia in what we need to do to have a more strong role in public policies for responding to epidemics and strengthening the public health capacity in our countries. So thank you very much, and looking forward for the discussion.
Thank you, Lida. And I would like to remind everyone that to go to the Q&A function on the right bottom and add your questions. It's now my pleasure to introduce the last speaker. Celina Turki is from Brazil. She's an infectious disease epidemiologist. She was instrumental in founding and coordinating MERC. MERC stands for the Microcephaly Epidemic Research Group. And Celina is also part of ZikaPLAN. Now, I want to share with you that Celina was selected as one of the 100 most influential persons in the world by Time magazine for her work in organizing and her early response to Zika in Northeast Brazil. Over to Celina. Please share your screen.
Okay. Good morning. Thank you, Annelies. And I received a warning here to be quick, to leave time for questions. So I just want to start saying that it's real pleasure and honor to join here in this webinar. And as you can see by the beginning, it's my first live webinar, so forgive me for not being so, it's a new situation for me. And what I want to say is that Annelies has challenged me to highlight in 10 minutes what the research challenge in the two pandemics, congenital Zika syndrome and COVID, have been. So I was trying to put those things together and see that, interestingly, these two pandemics were zoonoses from animal infections to human, even in highly urbanized areas, and its worldwide spread was by travel-related exportation, let me say like this. Both were considered X disease, not included in priority pathogens in the WHO list. In the Zika epidemic, we were at the epicenter of microcephaly epidemic in 2015 in the city of Recife, northeast of Brazil. The WHO emergency in February 2016 lasted approximately 10 months. And then what we had, a new disease named congenital Zika syndrome, and a vector-borne disease, Aedes transmitted, that caused severe birth defect. This was something really unexpected for the scientific world. I remember, for me, the most striking public health response to congenital Zika virus epidemic was the recommendation of delaying pregnancy during such epidemic. Now, in the COVID-19, a new virus was identified in China, coronavirus, transmissible from person to person, highly contagious, and another public health emergency was launched by WHO and still ongoing. So we have now a new disease, a COVID-19, that was named by WHO as it was named in February 19. So if I look back, the first challenge in the Zika epidemic was to call the world's attention. I think that was the main challenge for the researchers at the ground floor. As any novelty, this idea of a new syndrome was received with skepticism by the scientific community. We had to gather data about neonates, and the initial description of the cases of presumed congenital Zika syndrome in the early 2000s, I think, was very difficult. Just remember that there were many hypotheses including the use of rubella vaccine, larvicides, genetic disorders, pesticides, and so on. And we had really hard time to have the first case report published, since there was no reliable test at that moment, and we had to basically exclude all known infectious disease that could potentially cause microcephaly. And that was the scenario was this group, microcephaly epidemic group, were built. Now, if we go back, the public health emergency of international concern in Brazil, for us, it was a turning point. It's like an official statement. There was an important public health problem. Therefore, the call for research and fundings became available soon after. The population at risk were women and their neonates, and the control measure focused mainly on vector control activity. I believe that this pandemic will be remembered by neonates with severe congenital birth defect, their young mothers, and the inequalities of the living conditions. So causality was the top of the priority list for our group. We designed and conducted the first case control study in the region and had the support by the Brazilian Ministry of Health. This case control study was essential not only to prove the association of infection during pregnancy and microcephaly cases, but also to exclude the other hypotheses. I want to remember that research was embedded into the outbreak. Okay? So it was conducted alongside with implementation of surveillance and clinical guidelines as part of public health response. Now for the other research lines, I just want to remember this is exactly our work package in the ZikaPLAN that has been to unravel congenital Zika syndrome. So we have been following the children since then, and then the cohort of infected mothers. I'm not talking about surveillance because Lida had just explained a lot of the interface of surveillance and data analysis. Now, if we go to a typical curve of the congenital Zika virus in Brazil, you see the bars show the number of cases. So you see the peak in 2016 with the sharp drop in the following years. And the line is the cumulative number of cases. Just to remind that in 2020, there are still cases showing this low level of circulation of congenital Zika virus. Now, as for COVID, there are a lot of data, and this dashboard is from Johns Hopkins University from 3 days ago, that shows the cumulative number of cases in Brazil. So just knowing the detection was in February 2020 in Brazil, the speed of transmission has been remarkable. Now we can, in 6 months, we have more than 3 million confirmed COVID cases in the region and 100,000 deaths. Now, if we're going to think what will be the photos for this pandemic, I would say death grounds, and this tragedy has been also with a statement from the president saying, so what? And isolation and fear, I think, were the hallmarks of this epidemic. So our challenge as a research group was, again, the spectrum of COVID-19, what kind of disease is it? How does it develop? How severe it is? Another line of research was cohort study, was the risk of health professional with a very important component of mental health. And of course, the prevalence of SARS-CoV-2 in different population groups. So if we take a look, just for drawing the parallel about vaccine status, comparing the two pandemics, we use here the clinical trial sources. So after 5 years, the Zika vaccine status, none of the formula had gone to phase 3 trials. And if we go to within 8 months, COVID has already 8 large efficacy trials. And for the surprise of the scientific world, 2 already approved, let's see, vaccines like the Sputnik and the Chinese vaccines already approved in the short period of time. Just like to say that Brazil has been engaged or is engaged in several trials due to the sustainable transmission rate nowadays, and also due to reliable groups of institutions and research teams. Now, just to think about the intersection of these 2 epidemics more than the parallel of the 2 epidemics, when I look at our research teams that were involved in the Zika, most researchers were dragged to the COVID-19 pandemic, I would say our current war. Infectious disease clinicians, epidemiologists, and lab experts are now partially or totally committed with the current pandemic. Of course, the cohort and follow-up of Zika projects had to adapt by the limitation of the fieldwork imposed by lockdown restriction. For example, clinical follow-up of congenital Zika is now mainly online. Senior researchers like me had our everyday life changed with excessive demands and a lot of noise from scientific community and government. And we're in lockdown most of our time, being at-risk population. Finally, being an epidemiologist and working with infectious disease, both epidemics were recognized or are recognized as a human tragedy, but also as an opportunity. Collaboration is a learning process, needs training, and build trust takes time. Personally, it's a privilege to take part in the ZikaPLAN consortium and to embark on such scientific adventures with such a talent patterns and amazing friends now. Thank you for your attention.
Thank you so much, Selina. And I will now start with the Q&As. There are 2 quite related Q&As by Tom Solomon from the UK. His question is, do you think funders were quicker now to respond to COVID based on the Zika experience? And I'll put that to Sonia. And meanwhile, for the other 2, do you think Latin America was quicker to respond because they could observe the COVID outbreak in Europe and in China first? Over to you, Sonia.
Yeah, thank you, Tom, for this interesting question. I mean, I think that the difference, one of the big differences between the Zika epidemic and the coronavirus pandemic we're in now is that Zika mainly, at least at first, was affecting the Latin American population, and Corona is affecting everybody in a similar way, almost. So I think that also influences the funders, that they are more prone to respond because, for instance, in Europe, it's affecting the people in Europe and not people in Latin America. However, I don't have data on this, so I'm not really sure what the difference is, but I do feel like there is a different response. I don't know how the others feel about it.
Selina. And unmute.
Okay. Well, I think that response, there was a time where we could, I mean, in Latin America and in Brazil, the Ministry of Health could think about what were the control measures and how to prepare. Actually, what we had here in Brazil, it was a very important, let's say, misguide from the policymakers. I mean, the government would give very strong messages against control measures, like there was different, and I would say there was a very conflicting political moment that really hampered, I mean, control measures and things like this. And I still believe that funding got very late. I mean, we just started having call for proposal in the same old style and not considering that was an epidemic. I think the epidemic shouldn't follow the same call for proposal and the process that really takes time and just makes, actually, I don't want to be pessimist, but I think that it wasn't learned from the previous epidemic, that epidemics are treated different from the common health problems or routinely health problems, that epidemics are really different.
Thank you. And then maybe a question to Lida from Vijay from India. Between Zika and COVID-19, which one of the two outbreak or pandemic is worse, is more severe, and why, he's asking.
Yeah, I just want to comment in the previous one. I replied something in the Q&A, but as well, just to acknowledge something about the importance of ZikaPLAN in that, having that awareness. Because I remember for Zika, Selena calling me and writing to me, we have seen this microcephaly in Brazil, in Recife. How are you do there in Cali? What is the situation in Colombia? Very, very early in the epidemic of Zika. So just the communication between the two of us. And I also remember for COVID, you and Elise sharing what you were having, the experiences there in Singapore and how they were dealing. And I'm using all that information. I use it for Zika and I use it for COVID as well. So I think that part of the networking as well has been very important, and how to maintain communication between researchers, because that way you have more credibility to your colleague who is living the situation and giving, first-hand advice, rather than what you read in a paper or in the news or something like that. So I think that keeping that networking, that communication between ourselves, I think is very important. Whatever we see that, they say soft communication is very important, and also help us to provide the advice. And communicating the risk has been very important by the situations that we are deploying the news in Italy and Spain. That was very important for the community in general, not to say the formal channel of communication through WHO and PAHO for the governments. Regarding the question, I think it's so difficult. It's so difficult to answer that. I think one of the most striking phenomena of the two is that both viruses have a disproportionate burden in a very specific group of the population. So Zika, I mean, most of the infections are asymptomatic, same with COVID, but those that are disproportionately affected are the newborns. And it's incredible, it's disastrous, it's catastrophic what is happening to the newborns when a mother suffers prenatal infection with Zika. That's terrible for society in general. Even women and mothers are taking it in a more resignated way. They are more dealing with it in a better way than the society, I think. While for COVID, is our elderly people, are those who have chronic conditions, are so disproportionately affected. The fatality rates among them are evident. 80% of those dead in Colombia are over 65. So I think that's the key issue here. And sometimes when they ask me for the situation of COVID and how the society could respond, I say, imagine now that 80% of those deaths are less than 5. How do you respond in society? So for me, is that how these viruses are targeting, this is amazing to me, are targeting specific groups of the population where they deploy the highest burden. For me, that's the most severe issue. Then I still think that we need to better understand as society how to protect specific groups of the population with collective measures.
We also need to look at the overall numbers, obviously. There were about, maybe you can correct me, about 7,000 congenital Zika syndrome babies versus now more than 700,000 deaths.
But the ones are newborns and the other are elderly, so they compensate somehow if you want to see at the DALIs, for example. Mm-hmm.
Right. So then there are a few GBS specific questions. And one of them is, you know, sometimes you do not have an outbreak, you do not have an infectious disease agent. This is a question from Jesus Rojas from Peru. And so how can you actually identify the pathogen that is associated or that triggered GBS? Over to Sonia.
Yeah, very interesting question. I think, well, one of the things that happened in Peru in 2019 is that there was an increase in cases of GBS, and it was not known what was causing this. And because also there was Zika in that area at the moment, and chikungunya and dengue, at first it was thought maybe it was an arbovirus infection that was driving this increase in GBS. However, when you looked at the clinical phenotype of these GBS cases, they were mostly pure motor GBS, meaning that they didn't have any sensory symptoms. And when you were looking at the nerves in electrophysiology, they mostly had axonal damage. And this is a typical clinical phenotype for Campylobacter-driven GBS. So this was one of the reasons, of course. I mean, the easy question is, of course, you know, to test for several pathogens and to see which pathogen is driving the disease. But this is just to illustrate that also the clinical phenotype of the GBS that you are seeing can help you in sort of thinking about which pathogen might be triggering the disease. So in the case of the Peruvian outbreak, we also collaborated with neurologists from hospitals there, and we were able to identify that Campylobacter was indeed driving this outbreak and not arboviruses. So I think, you know, one of the things is that you can test for multiple pathogens, but the other thing is that you know, looking at the full image of, you know, what pathogens are occurring in higher rates in your country, but also what kind of clinical features do these GBS patients have, can help you in identifying which pathogen is actually driving an outbreak.
Thank you, Zika. And then maybe a follow-up on GBS again. And we all know that Zika is associated with GBS, but here's the question: how strong is this association for COVID? Or is it just simply an accidental finding between COVID and GBS?
Yeah, well, the quick answer is that we don't know yet. There have been, as I already mentioned in the presentation, quite some case series and case reports, but of course that could be a coincidence. There has not been very robust epidemiological data that supports that there is indeed an association between COVID-19 and GBS. There was one Italian study that did find an increase in GBS patients during the outbreak, but there has also been other studies that did not find this increase. So we just don't know it yet, but what we do know is that it's not the same as we saw with Zika, where you did see already early on a clear peak of GBS cases, and we haven't seen that. So in my opinion, at the moment, what we know now is that potentially Corona is driving GBS, but in a much lower rate comparing to Zika.
Thank you. And a question to any of the three of you, any volunteers here. So it's a question about the geographic distribution, and especially about Africa. So we know that Zika was mainly a problem in Latin America, and COVID is obviously a global problem, but both seem to be less, at least appear to be less in Africa. Does anyone want to answer the question why? Selena?
No, I don't think there is an answer for this question, but I suspect that we know little about disease in Africa. I don't know about surveillance systems in Africa. Of course, it was Africa in general must be too much. Only epidemics like Ebola or things like that have been registered more recently in African countries. So I think it's, I don't know if anyone knows the answer, I think I would be happy to know too.
Do you think there is some cross protection from other flaviviruses that may be more prominent in Africa to protect against Zika?
No, I don't think so, because we had some epidemics in African countries after, I mean, following Brazilian, I can, and they were reported and they were really detected as like outbreaks of congenital Zika syndrome. I think it's just because my point of view is not because there are co-infections or they have been exposed for a long time. It's just because we haven't looked closely to it and we don't have data about it. I don't know.
Okay.
Really, I don't know. I'm just guessing. It's a very wild guess, and I hope someone could give a better answer.
I do think there is probably some cross protection from other flaviviruses within Africa. That's probably higher. The endemicity of other flaviviruses is probably higher in Africa compared to Latin America. But I also still don't understand why Asia was also relatively protected against Zika. But here's another question about COVID now in Africa. Why does the death rate seem to be so much lower? The case fatality rate or the absolute numbers of deaths seem indeed are currently still lower in Africa compared to what we saw in Europe or the US or even Brazil. Does anyone have a potential explanation for that?
I do agree with Selena that Africa is too big to make a single statement. I think they are so heterogeneous and it's difficult to generalize. So I think it could be more interesting to discover certain patterns within Africa. So we have seen data from South Africa where they have the opportunity to have early introduction and on the situation that was nearly collapsing the health system. They still have troubles in certain areas dealing with the response for COVID. So I think it's also North Africa behaves differently. We don't know some areas that the virus hasn't arrived yet properly. Some of them are still starting the transmission. I think it's very early to make a general statement for the entire Africa. And at the end of the day, I think it's a combination of all of the hypotheses. So it's maybe some the ecological of the infectious diseases there, the living conditions, and also the strengthening of the public health surveillance system, even for death surveillance has been difficult. We know this from malaria and other diseases that recording deaths is a challenge in certain parts of Africa. So I think it's a combination of several things. For me, the pandemic of HIV, it's a very important one also to have lessons learned in Africa. So they thought as well that, you know, the virus originated there, but then it has a wave, then has different strain there causing terrible damage. So it's very early yet to give a general statement in Africa, I will say. Mm-hmm.
A question here from Osvaldo Fonseca from Umeå University in Sweden. Considering that SARS-CoV-2 is a zoonotic, has an animal origin, do you think in Latin America what could happen as now there's a spillover from humans to animals, and then that it could be then it would then trigger the outbreak to continue maybe through bats or other reservoirs? Any for Latin America? Any? It's for Selena. This is for Selena.
Well, it's hard to say always, I don't know. I mean, it's really early to know. But I think that as a pandemic, after the human population, we have such highly, say, populated areas with a lot of connection in airborne disease. I would just be concerned for the next 5 to 10 years and looking how the transmission rate within this population will happen. I don't think that the split from zoonosis, going back to from human population to zoonosis again, and back and forth. It may happen. It actually hasn't been a process that's being after it's, let's say, after the virus entered the human population. I mean, the transmission, the air-to-air transmission, and it's so powerful that going back to animals and being the animals the reservoir, that's the possibility. Okay, they're talking about, it was Today Science in about some animals that were found to be SARS-CoV-2 just today in the USA. But I think we still have to worry about the human-to-human transmission now for a certain time. Don't you think so, Annelies? You're just...
Thank you, Selina. There's a general question about networks. I think that Sonia already highlighted the importance of networks. So the question now is, should we invest more in networks, or keep the existing one and expand those? Sonia, would you like to take a go on this question?
Yeah, definitely. Yes, I do think so. I mean, I think that that we really now see how far we've come since Zika in our research groups and in our networks, because we can so easily get in touch with each other and see what everybody else is doing, collaborate in ongoing research. And so I think in general, probably I also would have said yes, before the Zika epidemic, because it seems to be, of course, you want to invest in networks, but now I think we've also really felt this in our personal and in our working life, that this really works. So yes, I do think that we should invest in networks, and also and the easiest thing is, I think, to continue with networks that are already in place, because as Lida also indicated, and I think Selina as well, is that it's also a part of trust of the networks that you have, that you already know each other, that you have already collaborated in a nice way, that you can continue more easily. So I do think that is key in facing this pandemic and also future pandemics.
Thank you, Sonia. And maybe I will use this opportunity to just quickly highlight what ZikaPLAN really is. ZikaPLAN is a European Union Commission funded consortium hosted by Umeå University in Sweden, that brought together partners, institutions, but also expertise from various parts of the world to address the Zika problem. And it was not only just one research question, but a whole set of research questions that can be better addressed if you work together as in a coordinated, in a network manner, than if you look at the questions individually. And indeed, also for COVID, the European Commission has now given and funded, or is now funding various consortia around Europe and also global consortia. So back again to a question from the audience here. The question is on vaccines. My question here is maybe to Lida. And in fact, Selina has shown in her slide that we have that there's an incredible race towards a vaccine now for COVID-19, with more than 20 now human trials. Whereas, while for Zika, there was initially a high effort, but not a single vaccine went into phase 3 trial. Lida or Selina, would you like to respond? Why did no single Zika vaccine go into phase 3 trial? And what does it really mean for us in case Zika does return?
I'm just going to say it very shortly that I think in general, vaccines and technologies for public health emergencies should be worldwide good commodities. So with that in mind, I will say that part of the restrictions or the barriers are the economic incentives to do it for those who have the capacity to develop very early. So there are lots of incentives to do it today. for COVID, which was not there necessarily for Zika. And there you see how there are funds now being negotiated between private pharmaceutical companies and entire governments, deploying incredible amount of risk public money, I would say, funds, for something that they don't know yet whether it's going to work or not. I think this is very, very interesting to analyze from that perspective, the economic perspective, which was not for Zika. I think that's for me, for a short answer, is a huge difference in how fast the response has been for vaccine development.
Okay, just to add, I agree with Lida, but just adding the comment about the scientific, results of the phase 1 vaccine for Zika virus is that most of them hadn't had, good first results. I think flavivirus are difficult. Just if we go back to dengue vaccine, how long did it take to, have a vaccine and then market it in the first place? And the second thing I would like to say is that we are still very short in good markers for flavivirus immunity, to Zika immunity. So serology, or let's say other markers, other markers aren't still very good. So I think from the scientific point of view, we had some bottlenecks with the Zika virus vaccine too. But I'm not an expert about it, but I agree and part of with Lida that the commercial aspect of it, and when you have such a huge vaccine for a neglected disease, for a vector-borne disease that would be confined to certain parts of the country, especially to the poor area, is much less appealing for the universal vaccine that you have the world population as a likely demand. They're buying the vaccine before it's ready. Okay, so that's huge. That's a huge difference between this aspect, the context, political aspects, and let's say what I agree, the numbers, the burden of disease is absolutely different. But I wouldn't like to judge who is the most important. I think Zika can be very important because we know by now it's not if Zika comes back, it's when and where Zika will have another outbreak of horrible congenital or Guillain-Barré syndrome, and a very terrifying for mothers and reproductive age, or for the women population in general.
If we had a Zika vaccine in the moment, would Brazil use it?
I think that to answer this question, that was very clever one. I would say that first we had to have a very good vaccine to prove efficacy. And that's going to be a problem, how to test a vaccine with a low level of transmission, where you don't have transmission to measure efficacy. So I think that the point that we should have something ready if another outbreak will come, so we can at least test the vaccine. And that's a good point. Thank you.
Thank you. Very short question by Jacques. What is the role of insects in COVID-19 transmission? Maybe to need a short answer.
Yeah, and I'm aware of some studies that they have ruled out some sort of involvement, but as far as I know, there have been very few yet to test it. Mm-hmm.
Thank you. Then apparently there is one attendee with her or his hand up. And Bonnie, if you could unmute this person so this person can speak.
Yes, sure. So Iskra, we have a participant called Iskra. I've just allowed you to unmute if you'd like to unmute and ask your question. Iskra, please go ahead. Please ask your question, Iskra. Ah, okay, Iskra's just disappeared, so.
All right, maybe then next question. Do you think that the IRB responses, so these are the ethic committee's responses to COVID-19, has improved compared to Zika in terms of fast tracking review? Maybe to Sonia.
I think it's a hard question to answer because I mean I haven't applied for IRB with a new proposal during the outbreak. Actually, because we were able to set up a study within ongoing study, which was I think part of what I tried to address in my presentation. One of the ways to have a research preparedness. But I think that at least in the Netherlands, the IRB system is the same. So I don't think that there will have been any changes. Although I can imagine that maybe in the in research groups that actually are researching respiratory diseases, that they might have already some kind of ethical fast-tracked review available. But in my perspective, I don't think that there is a much difference. But I don't know if Lida or Selina have any other experiences.
Yeah, maybe I can share what Sonja said, that I think that I was looking forward to this question because I think has been key in the response. And first is the distinction between what needs to go to the IRB and what kind of public health research doesn't need to go. And sometimes ourselves as academia or scientists who want to provide the data are not so sure about that. So to be able to consult to IRBs in whether the kind of activities that we do for outbreak investigation need to pass through their IRBs. And a lot of education, I think, needs to come up to future generation of researchers in working it out within the context of outbreaks, in what needs to go to a more formal process of IRB review and what it doesn't need to do because of the public health nature of the investigation. And one of the things that we did here was actually requesting a single IRB approval be recognized by the other IRBs, institutional IRBs. And they actually met and accepted it. And I think that was unprecedented. Even we have requested that for Zika once, and still with Zika, we have to go to 10 IRBs yet every year to renovate that. But while for the COVID outbreak investigations, we have a single one. And the other thing that has worked well is that we're now participating in some WHO-led multi-center studies, and they have been pre-approved by WHO IRB. So also helps a lot when we're coming back to our IRBs. So I think there has been changes and fast tracking that have facilitated the research.
Thank you. Here's another question from Africa. And I'm not sure whether we are really positioned to give a good answer because none of us is from Africa, but what are plans for research networks or research partnerships with African countries? Would anyone like to answer?
Well, with the EIGL study, we are already collaborating with South Africa, but that's the only African country that's currently participating. And one of the things that we would like to do with the study, because now we've already included a lot of patients. So, the number of patients that we include more is not really going to change the results I think that we will get with the 2,000 patients we have now. But what we probably will do in the future is to try to change or increase our network to countries or regions that are currently underrepresented, including countries in Africa. But we want to see if we can also change the protocol, for instance, to include a case control option in case there are new pandemics, etc. So this is something that is still work in progress, but I think we're definitely interested to also increase our network to more African countries to get a better idea of what is going on in case of GBS there.
One question here is, or actually one comment I would like to read out, is a very interesting comment from someone who now praises the Global Health Network platform. So we know ZikaPLAN is now co-hosted by the Global Health Network, and today's webinar is hosted by the Global Health Network. And she writes that she's been a member since 2014, and she really appreciates the networking response, and she's really trying to also overcome some of the research gaps with research in relation to COVID-19 research in Latin America. And she thinks that some of it was possible because of being a member of the Global Health Network. And in that sense, I would really like to encourage everyone to check out the Global Health Network. They have fantastic online resources, free courses, various platforms, and lots of access to data that is seriously that you should look at. So I encourage you to go to their website. I think I have a good question for Lida from the Facebook. For Lida, so it's considered academia always responds quickly to public health emergencies with a sharp increase in the number of publications, which we've also seen for COVID. For COVID, we now have more than 30,000 publications on PubMed. And in this sense, our response seems to be faster and faster. The vaccine response, by the way, to Zika was unprecedented at the time, but now COVID's vaccine response is even faster. So we are, our response is improving. But then she asked, but do we think publications are an indicator are they a suitable and robust marker for our increasing response? So for example, do the 30,000 publications we've had in the past 7 months, are they an indicator that we are responding faster? No, Lida, let's see what you say to this one.
Yeah, I love this question. So thank you very much. I saw in the Q&A, I already replied some of my thoughts. And this actually I question myself in whether to spend time writing the paper or actually doing the next thing or following up in the field what is going on. And I have answered myself this way. I think it's very important to have the publications, and it's a good indicator on the engagement of academia in producing this kind of information that is required, this knowledge, this research, even the viewpoints. I think they are very important in the outbreak response for both Zika and COVID. But I think it's not enough. It's so insufficient. It's so limited just to measure us by what supposedly we do best, which is writing papers, because they do not translate actually in what is going on in the field, what is happening in the day-to-day activities of the interventions, so what happened to people who is suffering the situation in the emergency situation. And I will think that we need, and it has been discussed before, a better indicator on the impact of what that publication or that information made in real life to people. And I have questioned myself a lot in what is our role there, because we produce the paper, but now we have to actually do policy briefs, something here called capsules. So I'm writing myself, summarizing some of the findings in WhatsApp messages. I started to use Twitter, which never used before. So that engagement in making that knowledge that's been produced there translate into public health interventions, into real life changes for people. I think we need an indicator for that. I think, and to do that quickly. Sometimes publishing just becomes secondary, just part of the process, but it's not necessarily the main objective.
Well, thank you. With these words, we want to come to a conclusion of the session today. A reminder for everyone that this webinar has been recorded and will be available by visiting coronavirus.tgthn.org, and you also have it in your chat. On behalf of ZikaPLAN and also on behalf of the Global Health Network, sincere thanks to the three panelists, Sonia, Lida, and Selena, for your time and your expertise and your thoughts and also our uncertainties in this rapidly evolving era. Thank you also to all you as participants for joining us today, for your interesting questions, for moving us along. And so from the team here, thank you very much again. Enjoy the rest of your day or your evening, wherever you are in the world. Goodbye and thank you.